Alterations in cardiac output and tissue perfusion. Heart failure. With cardiac function, the heart is a double pump. The right side will pump deoxygenated blood to the lungs for oxygenation, and the left side pumps oxygen-rich blood into the systemic circulation. This process provides a continuous supply of oxygen and nutrients, cellular metabolism and mechanism to help eliminate carbon dioxide. Disturbances in one part of the heart, if they are severe and prolonged, will eventually affect the entire circulation. Heart failure is the inability of the heart to pump sufficient blood to meet the body's metabolic needs. Ejection fraction is an estimate of the heart's efficiency, or the percentage of blood that the left ventricle ejects whenever it contracts. Normal ejection would be 55% or more of the blood that fills the left ventricle during diastole. With congestive heart failure, we see an accumulation of blood and fluid in the organs and tissues because of impaired circulation. We may see acute heart failure, in which there's a sudden change in the heart's ability to contract, and this causes life-threatening symptoms and pulmonary edema. With chronic heart failure, the heart's ability to pump effectively is gradually compromised, and the impaired contractility will remain prolonged. There is a class 1 heart failure, which is mild, and we see ordinary physical activity not causing fatigue, palpitations, or dyspnea, and there's no limitation of activity. With class 2, it's still considered mild. These clients are comfortable at rest, but ordinary physical activity will result in fatigue, heart palpitations, or dyspnea. With class 3, which is a moderate heart failure, there's a marked limitation of physical activity. These clients may be comfortable at rest, but less than ordinary activity will cause fatigue and heart palpitations. And then class 4, which is a severe heart failure, the client is unable to carry out any physical activity without discomfort or symptoms of cardiac insufficiency, and it occurs at rest. Discomfort will be increased if any physical activity is undertaken. So with left-sided heart failure, this will result from various conditions that will impair the left ventricle's ability to eject that blood into the aorta, and causes might include a myocardial infarction, cardiomyopathy, and hypertension. With right-sided heart failure, this will result from the right ventricle failing to eject blood into the pulmonary artery, and it causes congestion of blood in the venous vascular system. Causes would include left-sided heart failure, which is the biggest cause, and chronic obstructive pulmonary disease, or COPD. It's caused by an inability of the heart muscle to contract because of direct damage to the muscular wall. Now, compensatory mechanisms may kick in if changes in the heart function will occur over time. The body will use those compensatory mechanisms to temporarily improve cardiac output. But a reduced cardiac output, these clients are going to be hypotensive. They're going to have that low blood pressure stimulating the sympathetic nervous system to help release catecholamines, which are epinephrine and norepinephrine, to help raise that heart rate and blood pressure. So the increased force and contraction of the heart will maintain the blood pressure, but it also increases the myocardial oxygen demand. And that epinephrine is going to cause blood vessels to constrict, and the body will begin to shunt blood to the vital organs of the brain and the heart, but it decreases the supply to the kidneys. The ventricles also, with the stretching of the ventricles or the overfilling of the heart, is going to secrete the neurohormone B, B-type natriuretic peptide, also known as BNP, which is very specific to heart failure. So if a client has an elevated BNP, then we're pretty certain that they have a congestive heart failure going on. But the higher the BNP, the worse or more severe the congestive heart failure is. So medical management is going to include reducing the heart's workload and improving cardiac output. We can do this through dietary modifications or a low sodium diet, maybe even fluid restrictions or lifestyle changes, exercise, weight loss, and control of cholesterol levels. Drug therapy might be initiated with digitalization. Acute heart failure or pulmonary edema, sometimes we'll use a potent inotropic agent such as dopamine or dobutamine, and diuretic therapy such as furosemide. Vasodilators, ACE inhibitors such as captopril or ramipril might be initiated also. We can do a cardiac synchronization therapy, which would restore synchrony in the contractions of the right and left ventricles. And it's used primarily for clients whose heart failure is caused by dilated cardiomyopathy. An intra-aortic balloon pump would be a temporary secondary mechanical circulatory pump that supplements the ineffectual contraction of the left ventricle. Surgical treatment would include a ventricular assist device, which is an auxiliary heart pump that supplements the heart's ability to eject blood. Destination therapy, which is a mechanical circulatory support when there's no option for a heart transplant. Cardiomyoplasty is where the latissimus dorsi muscle is removed and then grafted to the aorta and wrapped around the heart. And then we use an electrical stimulator in a subcutaneous pouch to trigger that contraction of that skeletal muscle. And surgical ventricular restoration would decrease the size of the heart to a near normal size and shape by removing the dysfunctional heart muscle that doesn't contract properly. And a total artificial heart is an electrically powered pump that will circulate blood into the pulmonary artery and the aorta, replacing the function of both the right and left ventricles. As nurses, we need to teach medication, lifestyle changes, and diet restrictions, administer medications, and monitor for the therapeutic and adverse effects. We would also monitor for signs of excess fluid volume and evidence of electrolyte imbalance. Promote oxygenation and balance activity with rest, in addition to providing appropriate support to family members. When the left ventricle fails the heart, the muscle cannot contract forcefully enough to expel blood into the systemic circulation. Complications would include pulmonary vascular bed, where the fluid will accumulate and create congestion. Impaired gas exchange, where the cells become hypoxic and carbon dioxide accumulates in the blood. Hypertension and tachydysrhythmias, where we see valvular disease, cardiomyopathy, renal failure, and heart failure. The afterload, which is the force that the ventricle has to overcome to empty the diastolic volume, will increase with arterial hypertension, aortic stenosis, pulmonary hypertension, or excessive blood volume from renal failure. We see reduced ventricular ejection volume and a loss of elasticity in the muscle due to potential cardiomyopathy. These clients may experience hypoxemia, unusual fatigue with activity, exertional dyspnea, which is the first symptom, orthopnea, paroxysmal nocturnal dyspnea, which is sleeping with several pillows in bed or in a chair because they cannot sleep lying down. They become very dyspneic. A rapid pulse or irregular pulse, elevated blood pressure, cough, blood in the sputum, moist crackles, urine output is diminished. And with acute left-sided heart failure, we'll see pulmonary edema, hypoxia, restlessness, and confusion. We diagnose this through chest x-rays, which will show cardiac enlargement or fluid accumulation in the lungs. We also can use an echocardiogram, which helps determine the size of the left ventricle and the ineffective pumping mechanism. A multi-gated acquisition scan can measure a decrease in the ejection fraction. And arterial blood gas analysis, serum sodium, blood urea nitrogen might also be drawn, and a pulmonary artery catheter. With right-sided heart failure, the right ventricle cannot forcefully contract and push the blood into the pulmonary artery. Complications would include congestion of blood and backflow that accumulates first in the right ventricle and then the right atrium, then moves on to the superior and inferior vena cava and the venous vasculature. We may see chronic respiratory disorders such as cor pulmonale, which is a condition in which the heart is affected secondarily by lung damage. These clients may have a gradual unexplained weight change, dependent pitting edema, ascites, hepatomegaly, and jugular vein distension. The abdominal organs might be enlarged. They experience dyspnea, have fluid retention, where their rings or their shoes or their clothing becomes abnormally tight, and they have an accumulation of blood in the abdominal organs from anorexia, nausea, and flatulence. We diagnose right-sided heart failure with chest x-rays, an EKG, an echocardiography, which would show right ventricular enlargement, a lung scan or a pulmonary arteriography, and liver enzymes. So an elderly client has had a myocardial infarction of the right side of the heart. Which of the following signs should the nurse anticipate when assessing for heart failure? Edema in the feet and legs. With right-sided heart failure, that blood is going to back up into the systemic circulation. So that's when we see the swelling in the lower extremities. So which of the following client teaching points should be scheduled or included in the discharge planning of a client that has heart failure? And choose all that apply. This would be weighing yourself daily and taking your diuretic early in the morning. We want to take it early in the morning so the urination does not interfere with sleep. A client might be at risk for impaired gas exchange related to pulmonary congestion, secondary to left ventricular dysfunction. A nursing intervention to assist the client with maintaining adequate gas exchange would include all of the following except and that's providing foods and beverages that are a good source of potassium. We don't want to mess with the electrolyte levels if at all possible. And in this case, potassium is not going to be important in this treatment. Cardiogenic pulmonary edema is where the left ventricle is incapable of maintaining sufficient blood output and the lungs fill with fluid. These clients will have sudden dyspnea, wheezing, orthopnea, restlessness, and a cough that's productive of pink, frothy sputum, cyanosis, tachycardia, severe apprehension, respirations that sound moist or gurgling. These clients might be hypotensive and they might have peripheral pulses that just are no longer palpable. Diagnostic findings would be chest x-rays that might show pulmonary infiltration, ABGs that might indicate hypoxemia or hypercapnia, and a pH that's below 3.5. We manage it with supplemental oxygen or even mechanical ventilation. Drug therapy that would include dopamine or dobutamine, digitalis, and diuretics, ACE inhibitors, nitrates, calcium channel blockers, or morphine. We can do the intra-aortic balloon pump, the biventricular pacemaker, the LVAD, cardiomyoplasty, or artificial heart. As nurses, we need to get that IV line immediately established for medications, do bedside EKG monitoring, pulse oximetry, an automatic blood pressure and pulse measurements. In other words, we're taking them regularly at routine times, every 15 minutes, for example. And a urinary catheter to measure output, oxygenation, and do frequent oral care.